We will be going to the next session. The chair of this session will be our president, Professor Oloko, and the co-chair, Dr. Bozimo. So this is the Professor Dagogo Jack Award Lecture. And the speaker for this event is Professor Kolawale. Thank you for that round of applause. The topic is really interesting, the spectrum of hepatic involvement in type 2 diabetes mellitus. Good evening, distinguished senior colleagues and colleagues. We are on to the Dagogo Jack Memorial Award Lecture. And this award is the product of a memorandum of understanding between EMSON and Professor Samuel Dagogo Jack, who is hosting this in honor of the blessed memory of his parents. The inaugural Dagogo Jack Prize for Advancement of Endocrinology in Africa was delivered at the 45th EMSON AGM Scientific Conference. This year, the process of arriving at the award winner and lecturer was very rigorous, and it went through several rounds of selection process. And the speaker today, Professor Kolawale, came topmost amongst the several eligible candidates. Before he begins this lecture, it is traditional and it's part of the MOU that a brief citation of the lecturer will be given. So I'll hand the microphone over to Dr. Bolanle Opuno.
Thank you, sir. So I'll be giving the abridged bio sketch of Professor Babatope Kolawale, FWACP, FACP, FACE, FEMSN, Professor of Medicine and Consultant Physician Endocrinologist, Department of Medicine, College of Health Sciences, Obafemi Awolowo University, Ile-Ife, Nigeria. Professor Babatope Kolawale is a professor of medicine and honorary consultant physician endocrinologist at the Obafemi Awolowo University and Obafemi Awolowo University Teaching Hospital, Ile-Ife. He received his MBCH degree from Obafemi Awolowo University in 1989. Professor Kolawale completed his residency training at the Obafemi Awolowo University Teaching Hospital in 1999. He is a fellow of the West African College of Physicians, FWACP, American College of Physicians, FACP, American College of Clinical Endocrinologists, FACE, Endocrine and Metabolism Society of Nigeria, FEMSON. Please, let's give him a round of applause. Professor Kolawale's research interest is in clinical endocrinology with focus in diabetology, thyroidology, and malaria research. He is widely traveled scholar with many published articles in local and international peer-reviewed journals. Professor Kolawale is the current president of Association of Clinical Endocrinologists of Nigeria and past vice president. I think he's the past president of Association of Clinical Endocrinologists of Nigeria and past vice president, Endocrine and Metabolism Society of Nigeria. Immediate past head of endocrinology department in the Faculty of Internal Medicine, West African College of Physicians. Professor Kolawale served as a provost, College of Health Sciences, Obafemi Awolowo University, Ile-Ife, between August 1st, 2021 and July 31st, 2025. He has previously served as Vice Dean, Faculty of Clinical Sciences, 2008 to 2011, Head of Department of Dermatology and Venereology, 2014 to 2018, and Head of Department of Medicine, 2018 to 2021 at the Obafemi Awolowo University Teaching Hospital. Is happily married to Kikelomo Kolawole, a professor and consultant, orthodontist, Department of Child Health, College of Health Sciences, Obafemi Awolowo University, and they are blessed with children. To join me, let's welcome Professor Babatope Kolawole to give his Dagogo Jack lecture.
Thank you very much. Let me begin by acknowledging the President, ESCO of EMSON, for conferring this year's Dagogo Jack Prize for Advancement of Endocrinology in Africa prize on me. I deeply appreciate it. I will now proceed with the lecture. I'll be speaking on the subject of hepatic involvement in type 2 diabetes. I carefully selected this topic considering our local experience in this regard, and it also resonating with the theme of our meeting and our conference this year, that is complications of diabetes mellitus and its associated conditions. I must not continue without first referencing Dr. Samuel E. Dagogo Jack, who instituted this prize in MC. For those who may not have met Professor Dagogo Jack, he's a professor of medicine and chief of the Division of Endocrinology and Diabetes and Metabolism at the University of Tennessee Health Science Center. Professor Dagogo Jack was past president of the American Diabetes Association. He was also very, very prominent in those who attend the American Institute of Clinical Endocrinology meeting. Professor Dagogo Jack always featured prominently. He's an alumnus of the University of Ibadan and is a massive, massive, massive supporter of the growth and expansion of EDF, not just in Nigeria, but on the African continent. And we doff our hats again today for Professor Samuel E. Dagogo Jack. I think I'll be glad if you can help me appreciate him with a round of applause. This slide we are all very familiar with. This is the IDF 2025 Diabetes Around the World summary. Tell you one or two things. First, that diabetes prevalence is increasing globally, and also that in the Africa region, when we speak of projections up till year 2040, 2045, 2050, it is thought or expected that the Africa region bear the greatest brunt of the projected increase. This is not because we are reckless or because we are genetically predisposed. It is because we are not still doing enough to prevent this rising prevalence and burden of disease, especially diabetes type 2. Now, we look at the central role that the liver plays in intermediary metabolism in terms of both formation and disposal of glycogen through glycogenolysis or glycogenesis, or in the processing of fatty acids and even amino acids, ketogenesis, just name it. The liver plays a central role in all of this. Therefore, the liver is intricately connected with glucose disposal in the body. And there is a bi-directional relationship, I must say, between type 2 diabetes and liver disease, which I will be exploring in the course of this short lecture. And the global rise in type 2 diabetes parallels the liver complications, as we shall see. In what ways does liver or diabetes or glucose intolerance impact liver disease? And in what ways the liver disease itself impact glucose disposal? First, we see in this slide that what we call hypoglycemia awareness, that is increased impaired awareness of hypoglycemia, usually resulting from long-standing diabetes, may also be related to the functioning state of the liver. We know that reduced liver capacity that characterizes chronic liver disease, for instance, cirrhosis, also reduces the capacity for gluconeogenesis, that is formation of glucose from non-carbohydrate sources, and of glycogen storage and release. Therefore, patients with chronic liver disease may be unduly prone to having hypoglycemia. Liver-associated complications also predisposes to hypoglycemia in that sense, just also in a similar way as CKD or hepatorenal syndrome does. Cognitive impairment may also be accentuated, as well as diminished clearance of glucose-lowering medications and other associated or other similar substances that patients with diabetes use. Of course, we must also not forget that chronic cachexia, chronic malnutrition, and the sarcopenia that characterizes chronic illnesses, including liver in particular, may also affect glucose disposal in the body. Let's now focus on diabetes and the liver. We know that individuals with type 2 diabetes are at significantly higher risk of developing what we now know as the metabolic dysfunction-associated steatotic liver disease. This, in the past, was called the non-alcoholic fatty liver disease. I will still use both terms, and later we will hone down on muscle as the new nomenclature. In fact, some studies have suggested a 16-fold increase in the risk of muscle in patients with type 2 diabetes compared with non-diabetic individuals. This risk is primarily related and linked to metabolic abnormalities that are associated with type 2 diabetes, especially obesity, hypertension, insulin resistance, and dyslipidemia. And all these are included or are taken into consideration when defining muscle or NAFLD. So we see a bidirectional relationship between the two, type 2 DM predisposing to NAFLD, and NAFLD so also predisposing to type 2 diabetes. What then are included in the spectrum of liver disease in patients with type 2 diabetes? It begins with something as apparently innocuous as abnormal liver enzymes, especially alanine aminotransferase, ALT, are very, very common and prevalent in patients with metabolic dysfunction-associated liver disease. Also, the entity called NAFLD itself, non-alcoholic fatty liver disease, this affects about 34 to 74% of diabetic patients, with nearly 100% prevalence in those with obesity. And next to that is cirrhosis, which is associated with increased mortality in patients with diabetes, and particularly in patients that are treated with insulin. Hepatocellular carcinoma, as we all know it, diabetic patients have a 4-fold increased prevalence of this debilitating cancer, and is often linked to underlying liver disease. Acute liver failure is also thought to occur with higher prevalence in individuals with diabetes. Likewise, the prevalence of hepatitis C virus is higher in patients with diabetes. Let's take it one by one very quickly. Abnormal liver enzymes, I just cited there a few studies comparing non-diabetic with diabetic patients. In apparently normal individuals, a global study survey, general worldwide, gives a prevalence of about 0.5% prevalence of hepatitis C. Whereas if you take separate patients with type 2 diabetes, according to 2 large studies there, which are meta-analysis, the first is a conglomerate of 4 studies involving over 3,000, close to 4,000 diabetic patients. We recorded a prevalence of between 2 and 24% of abnormal liver enzymes in their cohort. In another study comparing 34 papers or 34 published work, including over 5,000 patients, 5.6% had elevated liver enzymes. So we can see from this statistic that individuals with diabetes are more predisposed to having abnormal liver enzymes. Cirrhosis is an important cause of death in patients with diabetes. Autopsy studies show that patients with diabetes have an increased incidence of severe fibrosis. What we know now as cryptogenic diabetes cirrhosis is mostly contributed to by diabetes in the United States. And impaired glucose tolerance is seen in 60% of overt diabetes and in 20% of patients with cirrhosis. In fact, the onset of diabetes in a cirrhotic patient is associated with decreased rather than increased insulin secretion. So that's the paradox of it. Hepatocellular carcinoma as well. Patients with diabetes have a fourfold increased prevalence of HCC. And we know that this increased prevalence of DM patients with hepatocellular carcinoma is the pathogenesis sequence of events leading to HCC appears to be linked with insulin resistance, increased lipolysis, lipid accumulation in hepatocytes, oxidative stress, and on and on and on, until the development of what we call the pro-carcinogenic state. So, diabetes itself is a pro-carcinogenic state. Acute liver failure in diabetes. The incidence of acute liver failure appears to be increased in patients with diabetes. Plausible attributable factors include diabetes itself, medications that we use to treat diabetes. We remember, all of us remember the story of albendazole, that it had to be withdrawn, not only because of increased propensity of worse cardiovascular outcome, but very, very more important because of hepatotoxicity. Hepatitis C in diabetes, the prevalence of hepatitis C virus, as we know, is higher in patients with diabetes than the general population. And patients with HCV are more likely to develop diabetes than patients with hepatitis B. That is 21% to 10% from data. HCV core protein impairs insulin receptor substrate signaling, and this is thought to play a role in the metabolic effects of insulin. Now, as we progress with the lecture, we now focus on muscle, which is the main thing I'll be speaking about. That's the metabolic dysfunction and steatotic liver disease in people with diabetes. Again, compared with the general population, you can see the huge difference in the prevalence of muscle and the propensity of patients with type 2 diabetes to have muscle. In fact, muscle is thought to be one of the manifestations of metabolic syndrome, a distinct manifestation of the metabolic syndrome. So we look at some definitions. According to the American Diabetes Association Consensus Report of 2025, published earlier this year in Diabetes Care, they proposed some definite changes in the nomenclature. First is what we now call the SLD, steatotic liver disease, which is an umbrella term encompassing different disease subcategories, all characterized by hepatic macrovesicular steatosis. Metabolic dysfunction-associated steatotic liver disease or MASL. This is defined as the presence of steatotic liver disease with at least one metabolic risk factor, including overweight or obesity, also hypertension, pre-diabetes or type 2 diabetes, and elevated triglycerides or low HDL cholesterol. Going together with this is the fact that alcohol consumption in the affected individual, for you to lay claim to this definition, must not be significant. That is, for a woman, not more than 20 grams per day, and for a man, less than 30 grams per day. And the composite of these manifestations then aggregate and we can say that patient has muscle. By the time we label an individual as having MASH, that is metabolic associated steatohepatitis, this implies the presence of hepatitis, steatohepatitis, and at least one metabolic risk factor indicator for steatotic liver disease, and then no alcohol consumption or consumption in a month not considered likely to cause liver outcomes by itself. And then, of course, the other categories, which you can look at, hopefully, I hope, when we get the slides. This nomenclature changes also is summarized in this slide, so I will not dwell so much on it. But the important thing that we must emphasize for muscle is that it is in the setting of not remarkable alcohol consumption, both in men and in women. If there's remarkable alcohol consumption, then that is alcoholic liver disease. That's ALD. And then, of course, we must make the distinction between steatohepatitis and steatotic liver disease. When there is more than 5% of liver cells having fatty accumulation, we say that is steatotic liver disease. But when there is inflammation and evidence of dysfunction, then that is steatohepatitis. MASLD in pre-diabetes and type 2 diabetes, according to world region and ethnicity, genetic, environmental, and socioeconomic factors explain the heterogeneous prevalence of MASLD around the world. In type 2 DM, the prevalence is highest in Eastern Europe, that is about 80% of MASLD. This is followed by the Middle East, 71%, and is lowest in Africa, 53%. 53% is huge, so we shouldn't think that because we are the lowest globally, that 50% is negligible. It is significant. It is not negligible. In the US, MASLD prevalence is highest for Hispanics, especially Mexican Americans, and lowest amongst blacks. These differences are most likely explained by differences in acquired risk factors, such as prevalence of obesity, diabetes, and socioeconomic determinants of health, as well as genetic polymorphisms. The pathogenesis of MASLD, metabolic dysfunction associated steatotic liver disease. This is as depicted in this chart, which I hope you can see from the back. Central to that is insulin resistance, which is the central abnormality in MASLD. It leads to increased lipolysis and increased circulating free fatty acids. This causes fatty acid overload, especially in the mitochondria, overloading the mitochondrial beta oxidation system. And then, of course, this leads to dysregulation of lipid metabolism, increased elaboration of inflammatory mediators such as tumor necrosis factor, as well as reduction of anti-lipogenic and anti-inflammatory factors such as adenopectin. And then, of course, going on from there, the oxidative stress leads to lipid peroxidation and then release of malondialdehyde and 4-hydroxynonenal, and then that progresses to cell damage, formation of malloryl-silane in hepatocytes, and of course, inevitably, fibrosis and inflammation if nothing is done. So what are the clinical implications of MASLD? These are implications especially for screening and further care. Early screening is very, very relevant and useful for early detection. The earlier MASLD is detected and intervention is instituted, the better for outcome. So screening is very, very important. Also because MASLD is a cardiovascular risk marker on its own, and because progression till late stages is usually silent and little or no symptomatology, little or no apparent changes in the patient, yet organ dysfunction and organ damage and failure are progressing rapidly. So how can we screen? In the past, emphasis used to be on liver biopsy. However, globally now, the emphasis on liver biopsy has diminished greatly people now seek what we call the NITs, the non-invasive tools. That is the in thing now. People are thinking that why go and take part of the liver when you can develop tools that are non-invasive, and that is the main focus now the main the way to go now when evaluating muscle and disease of the liver in diabetes. Again, to remind us of the progression, that is, the individual with type 2 diabetes or muscle starts with a healthy liver. This progresses in 20 to 30% of cases to muscle, in another 10 to 30% to MASH, cirrhosis 20 to 30%, and then 7 to 10%, 13% hepatocellular carcinoma. But the good thing is that if you screen early, interventions are possible at every path in this pathway. Diagnostic algorithm for risk stratification and prevention of cirrhosis in individuals with muscle. This is very, very important because these groups are individuals with the highest risk of muscle, people with type 2 diabetes, people with pre-diabetes, and obesity with more than one cardiovascular risk factor. Earlier today, Professor Ken was telling us cardiovascular risk factors and their assessment. So, if any of these high-risk categories have what we call a FIB score greater than 1.4 score greater than 1.3, then it's a definite risk for future cirrhosis, and that patient should be ideally managed by a liver specialist and also an endocrinologist. If it is not, then this patient can be managed in general practice. So this is how patients are generally stratified. Sorry, I think I need help here. That's done to Zoom. I need to take it. Technical. The slides are not moving anymore. The stock. Okay. Thank you. So, what are these? I mentioned earlier that the world has moved away from invasive liver biopsy to what we now call NITs. These are non-invasive tools. And these are the three major non-invasive tools that we employ in the diagnosis of muscle. Now, number one is the FIB-4 score. This is calculated with inputs from age, AST, ALT levels, and platelet count. Number two is VCT. That is vibration controlled transient elastography. It's a sonographic means of determining what they call the LSM. That is the measure of liver stiffness. This is determined ultrasonographically, and it's an aggregate, or a surrogate of liver histology. Also, ELF, which is enhanced liver fibrosis score. This is also a blood test that helps identify individuals with advanced fibrosis and at risk of developing cirrhosis or liver-related outcomes. Combining these NITs has almost made the need for liver biopsy unnecessary. And this is where the world is going now. So, interestingly, one of our supporters in this conference, Mega Life Sciences, I know they developed also a risk stratification score that can be used both by, let me quickly give a disclosure like Ebola Lady in the morning. Mega is not giving the dime for including this, but I found it in my search. I found that Mega Life Sciences had actually developed a risk stratification score. that can be used by anybody. Even the patient can use it himself or herself, as well as physicians, to stratify the risk of fibrosis and progression for muscle. And it is available at the URL that is stated there. And this is the landing page. This is where it will take you. If you just click on check your liver health, it will bring you to a page where you will input all the scores, all your data, and it can calculate your score for you. So I think we should thank Mega for that. So maybe I should send Mega my bill after the lecture for making their score category. So how do we manage as we begin to wind down now? Management is along these lines. Lifestyle, very, very important. That is loss of 7 to 10% of body weight. And this is best achieved through diet and exercise. And then, of course, optimizing glucose control. And then medications, especially medications that also treat diabetes. And then, importantly, to avoid hepatotoxic drugs. This just tells us the basic things about lifestyle. It involves weight loss, nutrition, therapy, healthy eating, healthy diet. It involves physical activity. It involves avoiding alcohol. It involves behavioral health and what we call diabetes self-management education. These are the pillars of lifestyle intervention in patients with diabetes and muscle. How about drugs? The type of medication you use will depend on the FIB-4 score. If a patient has F0 to F1, then that depends on whether he's obese, diabetic, or already has steatohepatitis. If he's obese, then the preferred medications are GLP-1 receptor agonist or the dual GIP GLP-1 receptor agonist. Ditto, this will also manage diabetes, and then of course for diabetes you can also use pioglitazone or SGLT2 inhibitors. For muscle F2 to F3 category, who are greatly at risk of MASH, then even for their obesity, we prefer GLP-1 receptor agonist or the dual GLP-1 receptor agonist. And then ditto for obesity, for diabetes pharmacotherapy, including pioglitazone. And then, of course, MASH pharmacotherapy, mainly GLP-1 receptor agonist. And then, of course, just down the line like that, by the time a patient has decompensated cirrhosis, then these medications should strictly be avoided, except the patient is diabetic, in which case insulin will be the preferred treatment. This everything I just said is also summarized in this chart, and if eventually the slides gets to us, we can go through it. It's just more or less the same thing, so I won't dwell so much on that. This again is summarizing the various considerations and the impact of blood glucose lowering therapy on different stages of muscle and MASH, from hepatic steatosis to steatohepatitis, fibrosis, regression, and the impact of these medications. And let's take SGLT2 inhibitors, for instance. It has query potential benefit for hepatic steatosis, but doubtful for steatohepatitis and fibrosis rejection. Whereas if you compare that with tirzepatide or semaglutide, you can see definite benefits for these medications, especially the dual GIP GLP-1 receptor agonist, in almost the entire spectrum of muscle, beginning from hepatic steatosis to steatohepatitis to fibrosis regression and reduction of fibrosis progression. When the patient has atherosclerotic cardiovascular disease, CKD, or heart failure, of course, the story changes, as we know. Sulfonylureas, little or no benefit, but in many cases, may also be neutral. So, as I conclude, I just want to share with us some of our own local data at the Obafemi Awolowo University Hospital in Ileife. Some of these areas of hepatic involvement. Sometime in the year 2000 and I think 2008, I spent some time with Professor Aisha Matala, you know her, in our clinic in Durban, in South Africa. And while there, we undertook this study amongst patients attending the endocrinology clinic. There we looked at patients with type 2 diabetes, and then over 300 of them, and we collected liver function tests. We ran liver function tests on all of them to determine the prevalence of abnormal liver enzymes in South African patients with type 2 diabetes. And interestingly, we found that several of our patients, let me read the conclusion, says there's a high prevalence of liver functional test abnormalities in this group of patients with type 2 diabetes. And this is particularly so in the morbidly obese subjects. And of course, if you've been to South Africa, you know that obesity is a major problem there. So this is comparable with what is reported, the reported prevalence in the Western world. Lipid abnormalities were more frequent in the group as well, with liver enzyme derangement. So, it is not something that is far-fetched. This is true that amongst type 2 diabetes patients, there are elevated or abnormal liver enzymes. In our own, in a local study that we did in some time ago, this was published in the Nigerian Journal of Clinical Practice in 2008. And in a work we did in our unit with a colleague in Tempat, Dr. Dagogo of blessed memory now, we looked at the seroprevalence of hepatitis C virus in Nigerians with type 2 diabetes mellitus. We studied the 115 diabetic patients. Interestingly, as at then, our preliminary results suggest a low seroprevalence of HCV among patients with type 2 diabetes. This is at variance with what we now know globally. However, we may say the N that we studied is small, and we did this study over a short period of time, looking at 150 diabetics who were then compared with 2,000 blood donors. So that number itself is, we have introduced bias. But these are things that we also need to look at now, maybe on a more national basis. We can commission groups everywhere, 5-6 centers, and let's look at is hepatitis C virus typically more prevalent in our patients than hepatitis B, and then we can come up with more valid data. In another study, which Dr. Damilola Amjo, which is actually the basis of our part 2 dissertation for the Western College of Physicians exam, we looked at insulin resistance and plasma glucose tolerance abnormalities in Nigerians with chronic liver disease. So we looked at patients with CLD and did the OMA-IR in them. Reading again the conclusion, it says glucose tolerance abnormalities and insulin resistance were highly prevalent amongst chronic liver disease subjects studied and seem to parallel the severity of CLD, which was determined by the TRIPUS score. So again, this affirms what is known globally, widely, that liver disease is characterized by glucose tolerance abnormalities as well as insulin resistance. However, this also still needs further exploration and more reports from other centers across our land. In spite of what we know, interestingly, the last paper I'm going to be sharing with us, which is the most recent of them, published in November 2022, and this is Ikem et al. We looked at the burden of diabetic complications in subjects with type 2 diabetes attending the diabetes clinic of the Obafemi Awolowo University Teaching Hospital in Ileife. It was a cross-sectional study. Why I brought this study is that in spite of all we knew, when we were doing this report, we did not take cognizance of liver complications. So it tells us again how often we tend to neglect or overlook liver involvement in patients with type 2 diabetes. And the purpose of this lecture, therefore, today is again to draw attention to this important complication of type 2 diabetes. That it's not just about the nerves, it's not just about the heart, it's not just about the eyes, but the liver. It also bears the brunt of type 2 diabetes. And on this score, I would like to conclude these takeaways. Muscle in type 2 diabetes is not innocuous. It is not something that can be overlooked. It is important because it can cause cirrhosis, it can cause HCC, and it is a marker of cardiovascular events. There is therefore a strong need to screen all patients with type 2 diabetes for muscle using simple indices, liver enzymes, ultrasound, and things like that. We therefore also, in the management of muscle, we need an integrated approach. It's high time we get involved as much as the hepatologists. The hepatologists are saying more, discussing muscle more, working on muscle more than we endocrinologists. It's also high time we take it seriously and we get involved. I think, what I have left to do now is just to thank and acknowledge our unit in Ile-Ife. This was a picture we took we didn't take this picture in Ile-Ife. Guess where we went to take it? In Calabar, in one of the EMSON. So that's one of the beauty of EMSON. Even it brings all of you together, all the family. So we are a big EMSON family. This was the Ife family in EMSON Calabar, except somebody that is trespassing, who came all the way from Uyo to dilute the Ife group. Can you spot the person? Who is the person? Where is Ubani? Ubani came, but we accept her. That means she actually identifies more with Ife than she does with center in Uyo. So on this score, I want to say a very big thank you again to members of ESCO, and I must not fail to acknowledge my wife who accompanied me to Lagos. Please stand up for recognition. Professor Kikelomo Kolawole, Professor of Orthodontics in the Department of Child Dental Health. Thank you again, ESCO. Thank you, everybody, for the opportunity and the privilege.
You have delivered an excellent lecture. To point, one was wondering, this could pass for the Class A inaugural. Congratulations, sir. So, as it is the understanding and agreement with Professor Samuel Dagogo, we are going to present the... Yes, why not? Prof. Mark, can you join Oga on the podium? Going to present this plaque to our speaker today, and awards winner of the Dagogo Jack Prize for the Advancement of Endocrinology in Africa for the year 2025, Professor Kolawole Babatope. Yeah, sorry, ma. Still, as part of the award, goes with yes, fine. As part of the award for this lecture is a check. No, I'm not going to do that. I'm not going to do that. The check is written in the name of Professor Babatope Kolawole, and this has completed our part of the assignment in fulfilling the MOU with Professor Samuel Dagogo Jack. So, on behalf of Professor Samuel Dagogo Jack, Endocrine and Metabolism Society of Nigeria, we are happy to present you this check. Congratulations.